Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative and UNFPA in collaboration with the White Ribbon Alliance and the Interagency Working Group on Reproductive Health and Crises for our event today in honor of World Refugee Day. Our event is titled Midwives and Crises, Securing Maternal and Newborn Health in Humanitarian Settings. I'm Sarah Barnes, and I'll be your moderator today. I direct the Maternal Health Initiative, or MHI, at the Woodrow Wilson International Center for Scholars in Washington, D.C. I'm joining you today from Bern, Switzerland. For those of you who are unfamiliar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses where we work to tackle global issues through independent research, open and honest dialogue, and actionable ideas. At the Maternal Health Initiative, we focus on a multitude of global issues, including maternal and child health, gender equity, and sexual and reproductive rights and health, as well as their connections to U.S. foreign policy. Today's event is co-sponsored by two other programs at the Wilson Center, the Environmental Change and Security Program and the Middle East Program. Our 13-year partnership with UNFPA, the UN Sexual and Reproductive Health Agency, has long centered on the important role of midwives in improving global maternal and newborn health outcomes. We're thrilled to also be partnering today with our counterparts at the Interagency Working Group on Reproductive Health and Crises, or IAWG, and White Ribbon Alliance. I just want to take a minute to thank all of you for all of your hard work and collaboration to support this event. And thank you to all of the panelists, both those who pre-recorded comments, as well as those of you sitting here with us today. Thank you so much, and thank you to my team at the Maternal Health Initiative and at the Wilson Center, and also a big thank you to all of you who are in the audience today, taking the time to join us for this really important discussion. The topic of today's event is central to all of our work, and it has been such an honor to work with this esteemed panel to continue the important discussion on the essential role of midwives in humanitarian crises. 66% of preventable maternal deaths and 45% of newborn deaths take place in countries affected by recent conflict, natural disaster, or both. The leading causes of both maternal and newborn death in humanitarian settings are considered to be preventable if managed by skilled providers and adequate resources. Each humanitarian crisis is caused by different factors, and as a result, each unique crisis requires a unique response targeted towards the specific sectors most affected. Humanitarian crises can be the result of natural disasters like floods or drought or earthquakes, man-made disasters including conflict, or public health emergencies like COVID-19 or Ebola, or they can be complex emergencies. And complex emergencies occur as a result of several factors or events that prevent a large group of people from accessing their fundamental needs, such as food, clean water, safe shelter, and healthcare. If such a crisis causes large movements of people, it could also become a refugee crisis with people being forced to flee their own countries, or it can cause people to be internally displaced within their own country's borders. For these reasons and a multitude of others, humanitarian crises are often interconnected and complex, with several national and international agencies playing a role in the response. The number of people living in humanitarian and fragile settings has increased significantly over the last decade, and women and children bear a substantial burden of the impact in these settings. Midwives have an essential role to play in preparing for and providing sexual and reproductive health services in humanitarian settings due to their unique knowledge and skills, position as frontline providers, and their geographic and social proximity to the communities they serve. In humanitarian settings, challenges to maternal and newborn health service delivery can include service disruption and facility destruction, population movement, competing priorities, and insecurity. So we have a lot to unpack today. And to do that, we've broken down this event into three sections. The first is a series of 3 pre-recorded videos focused on the role of midwives and frontline workers in Ukraine, Afghanistan, and South Sudan. Second, we have a panel of experts to speak to their experiences in maternal and newborn health in humanitarian crises. And third, we'll have a Q&A where the audience can submit questions for our speakers. So there's a chat box directly below the video where you're watching this event. So please put your questions in that box, and then I will work to incorporate your questions into the Q&A later in the event. So without further ado, I will introduce the speakers from the pre-recorded videos. First, from South Sudan, we have Lillian Ndinda, who is a maternal and child health coordinator at the International Rescue Committee. South Sudan has a protracted conflict, meaning that a significant part of the population is acutely vulnerable and dependent on humanitarian assistance over a prolonged period of time. They also experience as well as flooding and other climate-related issues, adding to their crises. So maternal mortality rates have consistently been high, and accessing healthcare can be difficult, and facilities are often not sufficiently staffed and have low levels of supplies available for midwives and other frontline workers. Lillian did a pre-recorded message, but she's also here with us today, so she'll be available later on in the event for the audience Q&A. The video from Afghanistan, we have a midwife who we are keeping anonymous for her own safety. Since the government changed last August, Afghanistan has lost gains in both maternal health and women's active engagement in society. Afghanistan faces a serious risk of backtracking to its notoriously high maternal mortality rates because of sudden drops in foreign funding, a shortage of healthcare workers, mobility restrictions, and worsened poverty. Restrictions on education for women and girls, as well as restricted mobility, deeply affect professions like midwifery. In yesterday's earthquake that has taken the lives of at least 1,000 people in Afghanistan has done serious structural damage and is likely to add to the existing stresses on the country. And our last pre-recorded video is from Ukraine, Dr. Olena Semelenko, and she's a neonatologist, and she's speaking about the role of frontline health workers to support neonatal health. At the start of the conflict, UNFPA estimated some 80,000 Ukrainian women were due to deliver a child in the upcoming 3 months. This is a timeline we've now surpassed. We've all seen the images of maternity wards targeted by Russian forces and heard details of the deaths of expectant mothers and of babies born too soon. More than 6 million refugees have left Ukraine, and another 8 million Ukrainians are internally displaced. So that's just a quick overview of the people who are in the videos that you're about to see. And Dikshita, you can play those videos now.
Good morning, good afternoon, everyone. As you heard, my name is Lillian, and I have started off working as a midwife in a tertiary hospital that is in Kenya. And I've also worked before in humanitarian refugee settings and hard to reach areas, fragile settings in several countries in Kenya, in Uganda, and in South Sudan. Currently, I'm working in program management and coordination, but I am in close working relationship with midwives in my role. And I would like to speak more on the challenges that actually midwives face during their work. And in comparison with when I worked in a tertiary hospital, there was a lot of standards. There was a little bit of everything. By everything, I mean resources needed for a midwife to attend to any woman who would coming in during ANC or postnatal care, or even to have a delivery. And sifting that into humanitarian settings, there was a bit of change, because the areas that I've worked in are either affected with conflict, they have weak health systems, they are hard to reach, they are fragile, and they have climatic changes that actually affect the delivery of health services. An example is South Sudan. It's a country that is marred by conflict, that has had protracted conflict, and also affected by climatic changes like floods. In these areas, midwives will work with a few of most of the items that they really need to provide quality health services. Due to the resources that more often than not are not sufficient to support these midwives in their work, you'll find that they are understaffed. They might have not enough of essential medical supplies, and they limit also the number of trainings that these midwives can receive during their during their work. And you find that most of those who are trained and they're experienced, more often than not, they are not based in humanitarian settings, or they're not based in hard to reach. So you find that most midwives who are in hard to reach areas are either the new midwives who have joined into the role, and therefore they require constant mentorship and they require constant training. In most of these humanitarian settings, you'll find that access is a problem, and access affects many things. It affects the delay of women coming in from their homes and coming to the health facilities, which means that midwives encounter these women when already complications have already set in, and managing these cases becomes quite difficult because they will need extra resources to support them. You find that in these areas, there are lots of cultural factors that come into play, hard to reach areas. Humanitarian settings also have a crossbreed of both host and refugee settings. If more often than not, the persons who are employed to provide the services are host communities, and here are refugees with different cultures. These cultures sometimes affect the quality of health services that are provided. More often than not, if I remember a place where I worked, let's say Dadaab refugee camp, it would take a mother several days to make decision on whether to take a cesarean section or not. And the reasons were they would need to seek several levels of approval from family members, from their father, from their mother, from their husband. Several people had to make that approval. And these strained health systems as well make the number of facilities to be very few. And when they're very few, then the distances that women have to walk to the facilities is also, as you know, it will take a long distance. An example, for example, in South Sudan, you'll find that despite in addition to the distance, is also floods and rivers that women cannot cross when they are pregnant to access the health facilities. So if by chance they are able to cross over, again, they will get to the health facilities when complications have set in, and this also becomes very difficult for the midwives to work in. The cost of operations in most of these humanitarian settings is also very high, again, impacting the number of essential supplies that the midwife will come across, and also affecting also the number of midwives who will have to be transported to those areas, because more often than not, that the hard to reach areas are also areas where you'll find that the capacity of the staff who are needed to work in these healthcare units are not sufficiently trained, or you require a higher cadre of staff to support, and therefore they have to move either from county to county or from province to province, or even sometimes from another country to this country. So these kind of problems that reach the midwife when she's delivering the healthcare at the end of the day, again comes back to her, and the mental health of this midwife is at stake. She or he has to work in an environment where he or she has to juggle between the quality of healthcare services, the cultural factors, and essentially what is available. And definitely they are expected to provide the same quality of healthcare that is standard in all sites, which becomes a heavy toll on her and a burden for them to provide services that are quite needed. In a sense, I think we need to really focus on the midwives providing services in humanitarian settings. We need to critically support their resources in terms of funding, in terms of their numbers, in terms of staffing, in terms of resources that they would have, essential medical supplies, referral systems that are actually working. More often than not, the referral systems are strained, either because of the roads are not passable and the floods, or they are affected, their security is at risk. We have had attack for healthcare workers in South Sudan of midwives or clinical officers who are supporting referrals from one facility to another, who've been attacked by bandits. And of course, the security of this staff is at stake. We will need to advocate a lot on the trainings and the support for this staff mentally to be able to work in these difficult areas, owing to the fact that they are juggling between different aspects of healthcare services. In some of the areas, you'll find that there's only one qualified staff, and this one staff is expected to provide midwifery services, as well as work in ANC, as well as work in postnatal care at the same time, also attend to a person who is sick. So I find that kind of burden of work for any midwife, I don't think they would have the capacity to work giving full time in such humanitarian settings for a long time. More often than not, they will either change positions to other roles, or they will have to leave the humanitarian setting. I think that's what I had for now. Back to you.
I would like to thank you all for giving me this opportunity to talk on behalf of Afghan women and midwives. Despite the significant progress in improving maternal and newborn health and lowering maternal mortality and morbidity from 1600, mortality from 1600 to around 700 per 100,000 live births over previous 3 decades. Afghanistan health system appears to be reversing since last year. I guess for the last 2 years, Afghan people have been facing many challenges, including poverty, insecurity, political and economic instabilities, and much more. The COVID-19 pandemic was an extra strain in the Afghanistan health community and on our health system as well. Unfortunately, the withdrawal of the worldwide technical and financial support, combined with the departure of large number of national and international professionals, this has made the situation of Afghanistan even worse. Right now, midwives and pregnant women have shared gender-related barriers, which is increasing day by day. Despite these challenges, Afghan midwives are still the frontline health providers in many fragile settings and continue to provide honest and quality care in public and private sector. We have many midwives who are the primary source of income for their family, but many of them have worked for months without being paid. We have midwives who are still continue working without enough supplies, equipment. For example, there's no enough masks, there's no even hand washing liquid or gloves. We have many midwives who are working more than 70 to 60 hours per week without any payment. But what they receive in birth of their services, fear of being attacked while working in health facilities, a lack of female healthcare providers' voice at the decision-making table, women, including midwives, facing discrimination because they are required to be accompanied by a male at all times. Both women, they serve and their female patients are affected by these rules and regulations. For example, decreasing the load of mothers in ANC, PNC, and family planning visits. Another example is a midwife killed in Mazar-e-Sharif while he was combined by his male colleagues to go to her job. What exactly happening in Afghanistan? The current situation significantly affects the people's hope for a brighter future, especially for women and girls. Afghanistan health system relies heavily on international donation, and system is the verge of the collapsing without the financial and technical assistance. We have witnessed human rights disasters in all areas of health, especially maternal and newborn health. There is no reliable data on maternal and mortality and morbidity, but we have heard from our midwives that these incidents are getting rise. The absence of the international community and human rights organizations make the new regime to not be accountable to the public and international for what they are doing against women and girls' rights. This winter will be much harder than last one because almost all medical supply and stock used, and without great attention to lack of the supplies could cause a huge crisis. Winterization is also another big challenge. My last point will be funding. The international support for Afghan people will directly impact the life of millions of Afghans before weakening the new regime. Education of women and girls in Afghanistan directly impact achieving for good health and well-being, and SDG 5 for gender equality. All three pillars of midwifery, education, regulation, and association, require significant attention and support to be invested from Afghan government and also donors in both technical and financial areas. In long run, future of mothers' health is strongly related to the education of today's young girls. Hence, the new regime must allow the girls to attend to school. The safety of midwives and health facilities must be ensured in order for Afghan mothers to benefit from the available health care. Midwives in leadership and managerial position, as well as their involvement in decision-making, can result in more effective and efficient planning and decision-making for mothers and newborn services. Still, the midwives are the frontline providers, ensuring they are well supported, empowered, and as the health workforce will also facilitate the quality and respectful maternity and newborn care in practice. To protect the community from harmful practice, the Afghan government and also our national and international partners should support the newly constituted Midwives and Nurses Council, which collapsed after this regime. Thank you so much.
Мене звати Олена Борисівна Самойленка, я лікар-неонатолог. В неонатології працюю вже 36 років. В наше відділення виходжує маленьких діточок, ті, які потребують допомоги. Перше, що я зробила, я приїхала сюди і почала готуватися до того, що могло бути. Ми розуміли, що для більшості це несподіванка. Враховуючи, що я це вже проходила, ми почали відразу в підвалах робити місця для наших дітей, для наших жінок. І в війну ніхто не кинув дітей, всі були тут. Деякі просто жили тут і виходжували наших дітей, допомагали мамам. Незважаючи на бомбьошки, на те, що доїхати не можна, медсестри приїжджали, всі були тут. І всі були біля наших дітей. Бо реально ми просто не зовсім готові були до цього. І ми розуміли, що треба буде допомога. І наскільки це ми дуже хотіли, щоб це закінчилось швидко, але, як ви бачите, воно продовжується.
Well, thank you very much, Lillian and Dr. Olena and the midwife from Afghanistan for those very honest and telling videos and portrayals of what the work is like in country for midwives and other frontline workers. Now we're going to shift gears into the second part of our discussion today, but just a reminder to our audience, if you have questions for the panelists, please put them in the chat box and we will be sure to incorporate them later in the discussion. So now I'm going to introduce our three panelists who will reflect on the three videos, but also will chat for about 30 minutes to get into more details about the work that they are all doing. And after initial introductions, we will revert to first names just to keep the discussion quite friendly and more intimate. So first off, we have Dr. Tamara Homosuritsi. Tamara is the Sexual and Reproductive Health Technical Advisor for the Eastern Europe and Central Asia Regional Office at UNFPA. Tamara has more than 30 years of experience in the field of sexual and reproductive health as a clinician, researcher, technical advisor, and manager. Welcome, Tamara. Next is Angela Naguku. Angela is the Deputy Chief Executive Officer with White Ribbon Alliance, a global people-led movement for reproductive health rights, and the founder of the Alliance in Kenya. Angela's career spans over 16 years of dedicated work towards ending preventable maternal and newborn deaths globally and amplifying the voices of marginalized and vulnerable populations in Kenya, throughout Africa, and around the world. Welcome, Angela. And finally, we have Mushtaq Khan. Mushtaq is the Health Technical Advisor and Sexual Reproductive Health Advisor for the MENA region, the Middle East and North Africa region in Asia at the International Rescue Committee. He has recently been working with IRC's Afghanistan and Northeast Syria teams to improve emergency obstetric and newborn care and basic emergency obstetric maternal and newborn care in their static health facilities, mobile health units, and at the community level. All of these maternal newborn health services are integrated and provided under the broad umbrella of comprehensive primary health care packages. Welcome, Mushtaq. So first and foremost, thank you again for being here today to discuss midwives and frontline workers in humanitarian settings. And the first thing I would like to do is turn it over to each one of you to reflect quickly on the three videos that you've seen, and then add more context beyond your bio that I just shared about your work and the areas that you work in, the regions, and also the technical areas. Tamara, I'll kick it off to you first.
Thank you very much, Sarah. It is my great pleasure and honor to participate in this important event today. Dear colleagues, first of all, I'd like to take this opportunity to pay tribute to all health workers, and in particular to midwives, who work on the front line supporting women, adolescents, and children during the armed conflicts, COVID pandemic, and natural disasters. Three videos reflecting the experiences of three countries are the best evidence of the role the midwives play, as well as the challenges they face. The context of the crisis in three countries is different. What is common, the fact that midwives deliver life-saving services in life-threatening conditions for all. In Ukraine, there were 295 attacks on buildings and facilities providing health services. This short video from Ukraine reflects only one part of the work of the heroes who deliver life-saving services for mothers and newborns. And there are many other roles the midwives play beyond maternity wards, providing antenatal care and postnatal care, supporting the survivors of sexual and gender-based violence, and protecting the health and rights of all people in need, despite of life-threatening conditions, destroyed infrastructure, and shortage of supplies. As we have seen, midwives have been playing an exceedingly important role in many countries facing humanitarian crises, like Bangladesh, Afghanistan, Syria, Ukraine, and many, many other countries. Midwifery is central to UNFPA's mandate to deliver the universal access to sexual and reproductive health and achieving three transformative results, namely ending preventable maternal deaths, ending unmet need for family planning, and ending gender-based violence and harmful practices. Today, UNFPA is the largest on-ground supporter of midwifery programs in the world in more than 100 countries. We know that midwives are making immense contributions to promote health, strengthening health systems, improving the quality of care, and contributing to rapid and sustained reduction in maternal and newborn mortality. In countries where we face humanitarian crises, we are further strengthening their capacities in implementing MISP, the Minimum Initial Service Package for Sexual and Reproductive Health, the set of life-saving activities, be it during COVID-19, the ongoing Ukraine crisis, or elsewhere. Couple words about Ukraine context and our programs. UNFPA programs in Ukraine engage the midwives and support midwives to respond to crisis. More than 4.4 million people has been reached, and more than 69 tons of essential health equipment and supplies have been delivered so far by UNFPA to equip midwives and doctors with necessary supplies, ensuring safe delivery, and also to provide them with necessary personal protection equipment and supplies. The midwives, nurses, and doctors are engaged in trainings to deliver life-saving services. They work together with doctors and outreach workers as part of UNFPA mobile teams responding to sexual reproductive health needs and sexual gender-based violence, and provide their services in the shelters and centers for women affected by violence. We are supported by our partners and donors, and I would like to take this opportunity to express our gratitude to the countries, organizations, and individuals for supporting us in making the birth safe, even during the crisis.
Thank you, Tamar. Angela, to you, please.
Thank you so much. And just like Tamara, I really want to take this moment to really acknowledge all the midwives, me being one of them and having worked in a conflict and a post-conflict situation and understanding the realities of what midwives have to go through. I always say that maybe had I not worked in a conflict situation or a post-conflict zone, I would not have become an advocate for frontline health workers and mothers. And I take pride in saying that actually working there and realizing the realities of what women and their newborns, and mostly the frontline health workers who have to be present when there are attacks from all sides, and when there are nothing to use, that actually drove me to say, now that I can't train enough as Angela, but I can use my voice as a tool to really amplify the voices of midwives as a frontline health worker, as one who has lived that experience, but also of the women and their newborns that I witnessed die and suffer because, yes, they are come to a health facility, but it was a health facility that was dysfunctional because of conflict. And so today I really want to say, I'm glad to be celebrating this World Refugee Day with others who are really speaking just like me and amplifying the voices of the frontliners who are most times not counted upon. I say this because I have listened, I've attended many conferences and I've listened to many maternal newborn health conferences, and I've listened to people, donors, governments, organizations, and people talk about investing in averting the crisis of maternal newborn health, of ensuring that we are investing in midwifery, investing in so many. I've read so many reports. I've seen so many commitments that are speaking to issues. But what I lack most of the times is that some of these reports actually make it contextualize anything to look like it's average. It's like we do not have crisis. We have no conflict. We only have a usual place where everything is okay. And so we have no women, we have no newborns, we have no midwives that fall within the other side of the curve, the normal curve. And that really pains me. And I'm glad to be speaking today because I'm speaking from the reality and I want to paint the picture of my first point of work where I started working in South Sudan, post-conflict. Immediately Sudan had just signed the comprehensive peace agreement. It's at that time that I went to work there. And what shocked me most is that there was no single midwife who was manning anything in all the places that I worked in South Sudan. And you'll agree with me that South Sudan is very big. I know in the map it's depicted as a very small place, but I can tell you it is so expansive that you can't even go. I don't even want to go beyond South Sudan to Darfur, the other area that I've been to. And so just being there and being present in a whole referral hospital without a single midwife and witnessing so many mothers coming, because organizations were coming and saying, now go to deliver in a health facility. Believe you me, I watched mothers die in that health facility. It was at this time that I had been trained in my home country in Kenya as a midwife and told you cannot conduct cesarean section because of the whole hierarchical issues that we have in the healthcare team. But I'll tell you that I had to practice with a fellow doctor who was there how to go about it because that was the only way I was going to save lives. Why? I had been posted there to go and work on a Safe Motherhood initiative to see what we need to do. But I ended up actually working in the facility 24 hours because I could not stand mothers dying because they could not be taken care of by anything else. More to that, during that time, there was a banditry attack. It was at the same time. I'm painting a picture of what happened, and that really has stuck with me to this time. The Lord's Resistance Army, the bandits from northern Uganda, actually crossed over to South Sudan. It was the very first time that I saw hospitals vandalized. They were already suffering. The health system was already dysfunctional. They are vandalized by the bandits. I am here as a midwife. I slept in a bunker for 3 days. At the same time, I'm thinking, what of that woman that I left in that health facility, almost like 4 centimeters dilated? Will I find her? Of course, I found some. Of course, I didn't find others. Yes, it was a place where we did not have good operating theaters. There was no referral system, as Lillian clearly painted. There is no referral system. There are no ambulances. The roads are dysfunctional. What do you do in such situations? And so, talking about the same issue in this point, I'm talking about 2005, 2006. We're in 2022. The same crisis is continuing. Nothing has been done. Midwives are being still counted in numbers. Nobody is listening to their realities. And the realities that have been painted in those places, Afghanistan, South Sudan, Ukraine, and so many other places, are not, and they are different, but they are the same. Mothers are delivering because, as we clearly know, and as we've seen with the pandemic, pregnancies do not stop with the pandemic. And so sexual activity does not stop with the pandemic. The crisis comes and finds women when they are pregnant. Families are still going on. Human beings continue being human beings. What do you do at that moment in time? I want to come again to the place where I am. 2 years ago, White Ribbon Alliance, in collaboration with the International Confederation of Midwives and others, came together to understand what quality reproductive health care means to women and girls. And as such, we listened to 1.2 million women and girls telling us what that means to them. And one of the things that they said is that they wanted respect and they wanted better supported midwives. And so last year, we came out to, and a bit of this year, to understand what do midwives want? What makes midwives not function? Why are we still having issues in maternal health? Why are we not improving outcomes, despite the millions of dollars that have been invested across board to ensure that maternal newborn health outcomes improve? Believe you me, talking to 56,000 midwives from across 114 countries, most of them being the post-conflict countries and marginalized countries in Sub-Saharan Africa and Asia, and some bits of Latin America, we realized that nobody takes the initiative to understand the realities of what midwives go through. I will say that we might not have gone extra miles to talk to those ones living in the fragile and conflict zones. And I'm sure we are going to do that because we keep on listening and acting and asking others to act on what we have found out as White Ribbon Alliance. We actually established that midwives are the back burner in decision making, in policies, in programs, in leadership, in salaries, in equity and everything. Imagine those are the midwives working in normal settings. Can you imagine what happens to that midwife in a humanitarian zone, where Lillian has really depicted quite well? And I've also showcased that to you from as a midwife when I started practicing as a young midwife. You're actually broken because your first initial reaction as a midwife is my own security. Is it provided? Because security is a basic human right. It's a basic need. Is it provided? What is the security of that mother and that newborn? What is the security of the place that I'm working in? The mental issues, the issues that you have to go through. Who really listens to me? Who really listens to midwives? And it's in this time that we actually took the initiative to actually go down deeper to where this conflict is really taking place and understanding what are the realities. I felt a lot of times that we talk about issues in very far places away from where the conflict is, from that reality. And a lot of times we talk about it like we don't understand that these conflicts are with us. They have happened. They happened many years ago. They happened last year. They will happen today. Yesterday we had a earthquake in Afghanistan. There will be an earthquake somewhere else. How much do we prepare when we're investing, when we are thinking policies and programs? How much do we think about that and in humanitarian settings? And I want to finish by saying that no life is better than the other. And the life of midwives And the mothers and newborns that are working in humanitarian settings is as critical as the life of any other person working in a normal street in a high life place in some big city somewhere. I also want to say that at the end of the day, if we are going to make really to say that we have made strides in improving maternal newborn health and the health of the populations, the global health of populations, we must acknowledge that midwives, women, their newborns are diverse and they live in diverse settings and their contexts are different and we must take into consideration. And we can only do that if we take a step back and put them on the front line to ask, what are the issues, what are the realities, and be present in their lives and understand what needs to be done for us to really to change that narrative. But until we do that, we'll keep on scratching the top and not really getting it. We will never say we've improved maternal newborn health outcomes across the board. Over to you, Sarah. Thank you.
Thank you very much, Angela. And now, Mushtaq, if you could share your reflections on the 3 videos and a bit more about your own work.
Thanks, Sarah. Thanks, Sarah, for having me, and thanks everyone for joining this very important event. And after listening to Tamar and Angela, not much left for me to add, but definitely I would say like these midwives being the frontliners, having a very great community acceptance, gender compatibility, easy access to communities. Still these midwives are across the globe. They are struggling in terms of remuneration, security challenges, as Angela mentioned, access to supplies, like even access to basic PPEs and getting embedded in formal health system, especially when it comes to community midwifery. So we really do invest a lot in midwifery, but when it comes to static health facilities, but when it comes to community midwifery, we really consider them as incentive workers, not as formal staff. And I'm talking to majority of the organizations we are working like when it comes to community midwifery, they are our incentive workers. And then same midwives working in the health facility, they are full-time health staff. So those kind of discrimination with both having the same education, same experiences, but related to those remunerations and the cadre which they are getting, it's not fair for them. And similarly, I would say like we do quite a bit of investments in community level health services, like when it comes to health and hygiene, house-to-house visits, ICCM, community surveillance. But if we could do the same level of investment at community midwifery, which like especially when it comes to recognizing them as a well-trained, geographically expanded kind of midwifery cadre, and investing in this cadre at the community level will have a very much direct impact on the classical 3D layers of MNH. So the role of midwife in disaster preparedness it's very critical. Bringing those midwives, in all these disaster risk reduction, preparedness, and response, involving them, it's very vital. Like giving you an example of the number of midwives in Afghanistan, like per 100,000 population, we have only 5 midwives. Then we have another cadre for 30 to 50,000 population, we have only 2 midwives. Then below 30,000, we have only 1 midwife. So how can we expect that we can improve those indicators related to maternal and neonatal child health indicators? How we can improve those when we are not investing in this particular cadre? And giving you another example from Yemen, where we worked, we really we were struggling with one of our activities at ICCM because we are not getting much of the community acceptance. Then we involved the community midwifery cadre over there. We expanded their roles, and we got huge acceptance from the community. Like they were providing the ICCM services, they were providing the health hygiene services, they were providing the other community level surveillance, along with their basic core services, like providing the basic SRH services, which is their particular mandate for them. So again, like as my other colleagues mentioned, bringing them into one circle, investing in community, in midwifery, particularly community midwife, involving them in DRR related activities, policy level activities, so that their voice could be heard. And especially we are having many colleagues from different organizations. We should be considering midwifery not as incentive workers. We should be considering them as proper staff, the way we have other staff or other health service providers. Over to you, Sarah.
Thank you very much. Thank you, each of you. I think that was really, really helpful to hear from the three of you. I think before we go on to some more questions, more specific questions, I was thinking it might be a good idea to take a step back and talk a little bit about what the primary maternal and newborn health concerns are in various crises. And I understand that in different contexts, these may vary, but if you could speak a bit more to the real concerns in humanitarian crises related to maternal and newborn health, and then also the specific roles. I know you've each touched on some of it, but the specific roles for midwives in these contexts, and what you've seen in different countries. Tamar, go ahead.
Excellent question, Sarah. Thank you very much. Among multiple challenges the pregnant women and their families face during the crisis, I'd like to mention 3 key points. First of all, I think main concern is the lack of facilities, supplies, safety concerns, security concerns, movement restrictions, which create additional barriers to access health services for women and newborns. And most importantly, I would say that we see weak capacities for immediate response to those challenges, which I think is additional challenge which the pregnant women see. Second, we know that during emergencies, sexual and reproductive health needs are often overlooked. Sexual reproductive health needs, including maternal and neonatal health, should be fully integrated and prioritized in preparedness and humanitarian response. Third concern, I would say, is the quality of preparedness plans. And we see the weaknesses in the preparedness plans in crisis situations, where midwives and health personnel are not considered as key building blocks of the health systems and emergency response. These plans are quite weak. And we see these problems, and then we see the problems making very strong impact on life and security of women, but also health force. I see the roles of midwives to address those concerns during preparedness phase, and I think this is one of the most important solutions to address those problems. First of all, participation of midwives in preparedness plans development and implementation. Second, strengthening the capacities of national midwifery associations. And third, international networking and mobility of midwives, which is important solution to make sure that the capacities, institutional capacities, are built to immediately respond to the crisis situations. I believe these 3 simple solutions will have very strong and long-term impact. Thank you.
Thank you. Angela, go ahead.
I think one of the things that is very clear and very key is that crisis sometimes is unplanned. But the reality of it is that we know that crisis does happen, irrespective of whatever crisis. And so at that moment in time, I think because we live in a world where a lot of times it's like we are caught off guard. We had not anticipated it's a crisis. But so most of the times our response is about survival. We never think about what next. A lot of times the response is about saving that life and ensuring that that life has food and the like. We tend to really overlook, like Tamar is saying, the other critical issues. And we, even over time, we've not learned that we need to take lessons from one crisis to the next. And as Tamara is saying, I think it's important and it's critical that whoever has survived and has been part of a crisis in a crisis response, like midwives as a frontline health worker, should not be left out when you're planning for the next crisis, or when you are shaping global health or global policies of country policies around a crisis, anticipated or whatever, and or most of the crisis is really uncertain most of the times. So if only that can actually be taken into consideration. I think the major concerns for communities in such places is that where do they belong? I think, as Lillian pointed out first, there's always a disconnect between the host country, especially I'm talking now about refugee situations and the like, or in displaced situations and the like, the organizations that are working there and the agencies working there and the communities themselves. And so it's always the people working there, and I'm talking this because I've worked in such setups where you don't know, it's like a no man's land. You don't know who belongs. You don't know, in case there's an issue, where do you go to? Who do you belong? You almost forget that you have rights. And I don't, a lot of times I don't understand whether the women and girls there themselves, the midwives there, and so to understand that they also have rights to really be able to speak up and say this. But because it's always a very hierarchical, bureaucratic way of dealing with things, that is always overlooked at the time. And I feel like there's really an issue, a mental health issue to the people living in such situations, because you almost like your life is at a balance. But imagine that you're a normal person. Now imagine you're a woman with a newborn baby, or you're pregnant, or you need a reproductive health service and you can't get it because you're in that situation. I think the other concerns around such is actually safety and security, because it's uncertain. You're living in a place you don't know whether your security and your safety is guaranteed. We've seen places where, and this is both for the communities living there, the women, the newborns, but also the midwives, because we've seen situations where we actually seen bombing and shelling of institutions, hospitals. We know they are protected, but you've seen that happening. So of course, who will feel safe if that has already happened in the past? I think there's also the aspect around, should complications arise, for example, where do you go? Because you're almost in an enclosed place, you're in a place, there are no systems so you're almost thinking about, it's either this pregnancy goes well or I'm dead. What really happens at the end of the day? So I think the other thing to really think about, and I think this is something that, now talking from a midwife's perspective, I think is as midwives, most of the times, and I'm speaking this also as a midwife who works in such place, you want to run away. And most of them do run away because their security comes first. And so they will go away and leave those mothers with nobody, because they're like, if their own governments are not caring about them, then who am I really to care? My security comes first. So at that moment, it's a very catch-22 situation. You want to save lives, you're trained to save lives, but at the same time, your own life is at stake. So where do you go? So I think and I'm saying this because I worked in a country where there was no single midwife. I went back to a community midwifery institution. I used to trespass places to places with floods, bandits and all that, to look for people to train, but there's no one because they have left the country. So what happens in that situation? Do we let those mothers continue dying because we can't get the right people? Or do we put the right frameworks in place, policies in place to really get it right, so that we can actually take care in case crisis happens? Thank you.
Thank you. And you touched on a couple of things that we'll circle back on once we bring Lillian back into the conversation. So thank you. I've taken note. Mushtaq, you unmuted as well. Do you want to speak a little bit about primary maternal newborn health concerns and crises?
Sure, Sarah, definitely. We know that humanitarian crisis impact significantly on public health, health infrastructure, delivery of health care, and mostly such crises appear and exacerbate where there are a series of pre-existing factors like poverty, inequality, lack of basic services, security concerns, and all this definitely result, such as humanitarian crisis, put these women and their children at an increased risk of poor health outcomes. And we all know that's because of loss of health services, no access to information, no essential social services, massive population displacements. And then we end up with situations like high numbers of maternal and neonatal deaths, physical and sexual violence increases, and this is coupled with limited or no access to reproductive health services such as family planning, ANC, PNC, natal services, EMOC. So like as Tamar mentioned, like if when we don't put these people like this cadre, I would say definitely this cadre, these midwives in emergency preparedness and response planning at all levels, like the local level, national level, international level, we cannot come up with some concrete solutions. And previously I mentioned like the numbers, they are very, very vague and they're very, very small. And if we want to come up with some concrete solutions, and we really want to decrease these mortalities and morbidities, we need to empower this sector. And during any crisis, we work really closely with MOH. But again, this midwifery associations, they are being neglected. As we see, like during any crisis, we immediately respond to communicable diseases, epidemic diseases, other waterborne related issues, but SRH issues are on like they come on usually on the back burner, and they are not taken care of immediately. We try to implement MISP in every emergency, but when we go to the health Minister of Health people, they are not very much receptive towards this. During these preparedness plans, we explain them that the importance of MISP, and they agreed. They do the promises, but when actual emergency comes, and when we want to have those areas like MISP to be implemented, and when we reach out to them, they are not very much receptive, and they are very much into other responses. So I would say like a lot need to be done, but it can be only done when we include this cadre in planning and response areas. Thank you.
Thank you. I'm going to throw it right back to you. Can you just, I know several of you have mentioned MISP, but just because our listeners might not be as familiar, can you speak a little bit more about what MISP entails? If you want.
Yeah, sure. I was because MISP is a baby for UNFPA, but still we are implementing MISP in every emergency. So MISP is a set of activities which we do from the start of any emergencies, and these are some set of activities which are prioritized before we go for comprehensive sexual and reproductive health services. So it includes coordination, in which we go for an organization. We come up with a SRH coordinator who is taking the lead in implementing MISP. Then we go ahead. Then it has another component which we reduce sexual and gender-based violence, and then infection prevention control. Now and then it's even now family planning is also included in MISP, and then BMOC services, which is basic emergency obstetric neonatal care, is included in MISP. And then when we really want to start with those set of activities in any emergency, and that's the minimum. That's why it's called minimum initial services package. That's the minimum we want. We don't want to have that comprehensive level of services. But when we had that, then we go for like in the second phase, we go for comprehensive SRS services. I can see Tamar unmuted. So Tamar, if you want to add anything.
Thank you very much. I'd like to add a couple of words about importance of integration of MISP in the preparedness plans. And UNFPA and its partners made all important inputs in this direction. In particular, the training on MISP is available in multiple languages, it's available online, and it's free. So I would strongly encourage all participants of the meeting to access the website, to access the training tools, and to take advantage of this excellent capacity building tool. Thank you.
Thank you both. That was very helpful. And kind of kicking off on that, and any one of you can unmute and respond to this next question. And you've touched on some of it already, but what kind of programs or policy changes are needed to ensure that maternal newborn health services are prioritized in humanitarian response and crises? Tamara, do you want
Yes, with pleasure. I believe that many countries have experiences and have evidences for policy changes. I'll touch base only on some priorities which are guided by our long-term experience of work in humanitarian settings and our recent lessons learned. UNFPA has been making significant investments in neonatal maternal health services, applying these experiences and innovative approaches. And from my side, I'd like to underline 3 key areas. We contribute and I recommend to all countries. First of all, this is about strengthening quality midwifery care through midwifery education and workforce policies, which is one of the key investment. We believe that midwives constitute the health workforce that can help deliver around 90% of essential sexual, reproductive, maternal, neonatal health services when properly trained and supported by enabling policy environment and health system. And we're talking about both development and humanitarian settings. This investment is crucial, and this is also documented with the latest findings from our global SOMI report. This is status of midwifery report, which is the assessment is conducted every 5 years, and we get fantastic information about gaps, and we elaborate the recommendations to address those gaps. Second, this is about advancing the quality of preparedness plans, and in particular, strengthening the sexual and reproductive health services component in the national preparedness plans, considering the health systems blocks and national institutional capacities to deliver maternal and neonatal health services in any possible scenarios. And third, and I would say very important, this is about education and protection of health workforce to deliver effective response to the crisis. In addition, I think that we should invest in strengthening national midwifery associations. We should support them to strengthen their international networking, because we believe that midwives working in crisis situations are our agents of change. They are our ambassadors in health diplomacy. Thank you.
Wonderful, thank you. Angela or Mushtaq, do you want to talk at all about policy and programmatic changes? Go ahead, Angela.
Thank you. I think just to add on to what Tamar was speaking about, I think one of the things that if we have to do if we are to make any policy or programmatic changes is to learn the lessons and to adapt the lessons. A lot of times I feel like there's so many lessons that we learn. Like, let's say, for example, there's so much that the pandemic has taught us, but are we going to really use that in making the next global policies, national policies, organizational policies, or the like? I feel a lot of times we have what it takes. It's only that we do not want to go back and look at our books and say, what are the lessons? So I think the first thing to making changes is to really take on those lessons and take them forward. I think also the other thing is to interrogate the gaps in terms of what in making these policies, where are the gaps? And I think I spoke to some of those gaps, and some of them is listening to the midwives themselves who are in those frontliners or who have worked in those front lines, or in the conflict, in crisis, or organizations like UNFPA, like Tamar is talking about, like Mushtaq is talking about. What is the reality? And a lot of times I ask, who are normally called on to shape, for example, a humanitarian midwifery policy? There should be the people on the front lines, midwives themselves, the leadership themselves, but also organizations that are really on the front lines in those spaces. I think the other issue is to be ready and acknowledge that crisis is bound to happen. So I think is to plan to have policies and programs that integrate emergencies response in them. And it must be integrated enough to go beyond the communicable diseases that Mushtaq is talking about, to actually think about reproductive health, think about other aspects, socioeconomic health aspects that come to play. And who are the experts in that space that need to come to the table? Because I will just give examples of what I've seen in different countries, like in Africa during the pandemic, where the task forces that are driving the response actually lack people from the social aspect. They lack people from the economic aspect. They lack people from the education and midwifery aspect. Then you only bring about the epidemiologists. You'll not be able to respond holistically. You'll only respond one-sided. So I think that should be a lesson that needs to be taken forward. I think the other aspect that we must embrace is the aspect of equity. Even when we are thinking about responding to emergencies, we must think of it from where is the place, where are we coming from? In terms of, if it's a context, for example, in Ukraine, where was Ukraine coming from? If it's Afghanistan, if it is Syria, if it's Yemen, if we are talking about South Sudan, what is the starting point? And where is this? And what is the gravity of the issue? And how long is this looking at? Are we looking at? And who are there? Women? Are there midwives? Are there health workers? And what needs to be taken into consideration when we are addressing that? Let's not address a few things and leave the others, which are equally critical. So we cannot really move forward until we are able to really ask ourselves those critical questions. I think the last thing that I would say that we must anticipate and plan. We cannot anticipate because they are there. They have been there before. They are present and they will be there even in the next few years. So I think that is, and really think fragility, conflict, humanitarian as an aspect that should not be an afterthought. It should be in the front lines as we are thinking, shaping maternal newborn health, midwifery agenda, health, global health agenda. Should never be an afterthought. And we should be held accountable and allow ourselves to be held accountable. I feel like there are a lot of millions of dollars that will go to humanitarian response. But where exactly does it go if we are still losing mothers and newborns? Where exactly does it really go to the ground? Or does it remain in the big offices, in the centers where it originates? I think those are things we need to really introspect and ask, where is accountability for the women and girls, for the midwives on the front lines? I think I'll leave it there. Thank you.
Wonderful. Thank you so much, Angela. Pushtak, did you want to talk at all about policies and programming?
Just want to add another point, the point which Tamar was mentioning at the policy level, like those national emergency preparedness plan, they need to include it. But I also want to really we really need to bring this midwifery care into the mainstream health system through all those health system strengthening blocks, and we need not to consider them as an auxiliary cadre. So like until you don't bring them into the mainstream health system strengthening blocks, you cannot get the desired output, I would say, from this cadre. And as Angela was mentioning, it's about the equity. So when there will be no equity among the service providers or among the frontliners, we cannot expect much from this cadre. So yeah, I'll like these are my 2 cents for this policy level thing.
Great, thank you. And you all, actually, you've all now touched some on this, but maybe we could just briefly, before we turn things over to the audience, and just a reminder, if you're in the audience and you have questions for our panelists, please put them in the chat. After this question, we'll move to the audience Q&A part of this discussion. But I wanted to, because each of you has touched on this, and I know it's part of the theme of this conversation today, but if we could talk a little bit more about how context determines response, and how important is it for a country to have already had a strong health system prior to crisis, when crisis hits? It's kind of 2 parts, but really kind of just trying to look at the context question and the health systems in place. Tamar, go ahead.
Thank you. We have clear evidences over several decades that the crisis situations make more significant impact on countries with weaker health systems. And especially this impact is even more catastrophic when we are talking about countries with limited experiences of emergencies in past. And I would say that our region is one of those with very limited experiences of conflicts. And I would say that Ukraine war is the largest scale crisis in the region since the Second World War. So I would say that crisis situations are the test of health systems' strengths and weaknesses. And I believe that the experiences, especially experiences of COVID pandemic, experiences of wars and recent crisis situations should serve as a very strong lesson learned to apply to the programs which are aimed at health system strengthening. Stronger health systems we have, stronger focus we have on health service providers blocks, stronger midwifery task force we are getting. On another hand, stronger capacities of midwives in the countries contribute to the strengthening of health systems. So I believe that on one hand, we should definitely apply the lessons learned to the programs to strengthen health systems. But on another hand, we should utilize the potential of health workforce to strengthen health systems. But before, we definitely need to invest in this area. I believe health workforce, and in particular midwives, should be prioritized among health systems blocks as the area of investment with long-term positive impact. Thank you.
Thank you. Does anyone else want to quickly answer that question, or shall I move to the next question? Okay, I'll move on. Lillian, if you, oh, Angela, if you, did you want to say something? Go ahead. Lillian, you can come on, great.
No. I think we can give it over to Lillian. Thank you.
Okay, great. So one of the questions that I also wanted to ask and include you, Lillian, in this conversation, and thank you for joining us live today. One of the questions that's come in and is also on my mind that has been touched upon is the question around mental health. And I'm wondering if you could speak a little bit to the impacts of conflict and living in humanitarian or fragile settings on the mental health of both, women and children, but also on midwives and other frontline workers. Lillian, if you want to start, you can, and then we'll go around.
Thank you very much, Sarah. I think mental health issues around women and girls, as well as in humanitarian settings, have not really been given the attention that they deserve. And more often than not in humanitarian settings, we are, our priority actually is to provide safety, to provide quick interventions, and really mental health comes in much later. We have organizations, for example, IRC, who will provide internal mental health support for all staff who are working in the midwifery side. But you will find that some of these staff actually, by the virtue that they are working in hard to reach areas, they are not able to access the mental health support that is provided by the whole organization, that is via email or via internet. And this midwife who is in a far to reach area is not able to access that. You also look at policies that are govern mental health, and also programs that are targeting mental health usually do not really look at those persons who are already affected. They only look at persons who are already affected. For example, persons with schizophrenia who have already in advanced mental health disease, but not really persons who are really having problems coping at work and having an avenue to actually air the problems that they have. I think it's an area. I was actually reading a paper this morning, and I was very happy that the Kenyan government has actually, for example, moved into policy the mental health bill. And the mental health bill in Kenya, it was last reviewed in 1992, 20 years later. So this is actually a milestone. You're looking at health workers who are actually taking their lives away during at work and with suicide, and no one is explaining what is the reason. You'll find that, even as I explained in my video much later, that in humanitarian settings, it's really hard to find somebody who's worked in that setting for more than 15 years. It's hard to cope So more often than not, you'll find that the staff will leave and they'll seek out to either other less stressful areas. And I think it's something we need to focus on. Just as we focus on training a midwife to become a better midwife in providing the actual skills, then let's also focus on how can we actually help the midwife cope with the stress that this work comes along with it, because it's different. What I faced as a midwife in Kenyatta National Hospital or in Aga Khan Tertiary Hospital is very different from what I faced as a hospital nurse in charge in the Dadaab refugee camp. That was quite different. And I think I wasn't prepared for it. So you learn on the job and somehow you talk to colleagues, but we need to address that issue as much as we can. Over back to you, Sarah.
Thank you. Thank you so much, Lillian. I conducted an interview about a week ago with an advisor from UNFPA who's working in Ukraine, and she was saying that they're seeing some preterm deliveries that they're associating with the high stress and mental health of women who have been affected by the conflict. So I think that this is something that people are hopefully starting to talk about more. I know maternal mental health is something that people are starting to focus on more. So to your point, we definitely need more for both midwives and the women and children that they serve. Does anyone else, before we go to the next question, want to touch on the mental health question?
A quick question, Sarah. Yeah, we usually do quite a bit of programming on mental health of concerned population, like through community-based and facility-based mental health programming, but not much done on mental health of the healthcare service providers. Like Lillian mentioned, like we do have in IRC a very good system of remote mental health counseling and those sessions which we can take. But again, the frontliners, they don't have access to that level of connectivity to reach out to that. And by the end, we see a lot of burnout, like burnout in terms of mentally, physically, socially. They are burned out, and we lose. There is quite a bit of brain drain from the organization because of these mental health issues. So I would say like organizations can take steps to reduce the psychological impacts of disasters on employers. Like this could be done through provision of on-field, on-site kind of trainings, workshop, incorporating mental health to reduce the stigma, team building exercises on the spot, on the ground at where the frontliners or the frontline workers are. So this will really help in supportive workplace relationships, I would say. But yeah, it needs a lot of attention to be paid.
Wonderful. Thank you very much for that. And then now I'd like to move on to some of the questions we're getting from our audience. The first question is, and we can see whoever would like to unmute and respond to this, please do. Can you provide examples of the positive outcomes that come from making quality midwifery care more available in your context? So really getting, going back a little bit to the basics, what service, what ad are midwives able to make in your context? Mushtaq, you unmuted, would you like to go?
Yeah, definitely. Like out of all these, challenges, difficulties we have discussed around the scatter and around different contexts, I would like to share an example with a very good and positive outcomes. Like I will further elaborate that German example. Like we started an ICCM programming over there. We were getting community backlashes and like backfires that how you can train few people from the same community for a couple of weeks, and now they are treating our children under 5, and they literally use the word that how they become doctors in 2 weeks. So like we were really struggling to kick off that programming. Then we already had that our geographical mapping for community midwives over there, and we knew that these community midwives, they are very much accepted in the communities. So we extended their role. We trained them on ICCM treatment protocols. We trained them on communication skills, and then on basic health and hygiene messages. So and then with their extended TORs, we increase their remunerations also, and those they become like our service providers at the community level with extended role, because they were linked to the static health facilities in the catchment area of those populations. So they're referring patients for any BMOC services. Then they are doing house to house, they're providing ICCM treatments. And like it was a really good and great positive outcome we have, that we include this cadre not only for mental health, not only for sexual and reproductive health, but in other sectors like subsectors, because of their huge community acceptance. And also these are the only people at the community level which are formally trained. So why not to use further elaborate their TORs and their roles to get better and extended outcomes.
Great, thank you. Tamar.
Just some experiences from our recent practices in Ukraine, Moldova, Belarus, other countries also, where the refugees are at present. UNFPA supports the trainings of midwives, community workers, nurses, doctors, to provide a response to the people affected by the crisis in Ukraine. Right now, across Ukraine, UNFPA is coordinating 10 shelters, 8 crisis rooms, 3 daycare centers, and 9 service delivery points, where the services are provided by multidisciplinary teams to address physical and mental health problems of the people. There are 9 orange safe spaces established in Moldova, which provide the services to women, but also to young people and elderly. And there is 1 additional orange safe space in Belarus operating. So here I'm making the point of need of post-diploma training, context-specific training, and also delivering these capacities and knowledge to people. One of the examples is mobile teams who operate. We have a midwife, a nurse, outreach worker, doctor. So this team provides integrated SRH services traveling in the region. So I think these are some of good examples where we managed to build capacity and to establish the points where these capacities and these services are better accessible for people who need it. Thank you.
Great, thank you. Angela.
I think first to answer that question, we know that over 80% of maternal newborn childbirths actually attended by a midwife. And in most of these places, you'll find a midwife. And so across board, midwives are really like, they're the frontliners in almost every situation. So they are really critical in every aspect. Just to give an example from South Sudan, I remember when I went back to South Sudan in 2007 to really like train community midwives, and we really looked for midwives, even those who are really low trained, to really start community midwifery, because we needed people from the ground, not people coming, not experts coming from other countries because they would leave. We needed sustainability. And so we started by training them English and the basics of what communication is all about. And after 1.5 years, after 18 months, I was so happy to go back or to go to the different spaces, different regions, counties in South Sudan, to find at least a midwife in almost every space, that they are providing care to the mothers, and so mothers do not need to walk long distances or to die, and they can be able to track them in that community. And for me, that is an example of homegrown midwifery in that spaces where they can actually be able to communicate, talk to them, understand their context, and respond in a post-conflict situation. Yeah.
Wonderful, thank you. Mushtaq, did you want to make another comment? Go ahead.
Yes, Sarah, if you allow me, I really want to share a very good practice we had, and a very much first-hand experience we had in IRC, this cross-sector integration through midwives. Like in our one protection empowerment sector, we have those women and girls safe spaces, and those are the spaces where women and girls, they can easily go and have easy access. So we were really seeing a decline in our SRS services in our health facilities because of a lot of odd issues like privacy, confidentiality. But these aspects are really were really taken good care of in those WGCCs or WGSSs. So what we did, that we deployed a trained midwife in those WGCCs and like the women and girl safe spaces, and we got some amazing results. Like women, they were like really they opt for all like the basic SRH services, antenatal, postnatal, referral for natal services, STIs treatments, family planning, short-term methods, and then referral for long-term methods. Like we got a lot of data from that, and it was really quite a really amazing success we had of like deploying midwife into those safe spaces, and a very good example of cross-sector integration also. So we are replicating that model in other countries. Like we had we have this successful model in Myanmar, Yemen, but now we are replicating in Syria and where the context allows us.
Wonderful, thank you. And Lillian, you can touch on that if you want also, but we only have 5 minutes left. So I want to also throw the last question to you. If you wanted to also touch on the final question from the audience, and that is, how do we better include midwives in emergency preparedness and response planning? And what are, if any, what are the global health system barriers that we would need to consider in that?
Thank you very much, Sarah. One of the areas that Angela talked about was that when we are doing the response planning, even the national emergency preparedness planning and response planning, we rarely have persons who are actually going to advocate for sexual and reproductive health, which is actually, if you look at the new MISP that was launched recently, and the components that you're supposed to check out if actually MISP is fully functional, the emergency preparedness and response planning should include members who are actually advocating a series of SRH issues. And by issues of SRH, it includes even persons with disability. Women who are living with the disability actually face more problems during any emergency. So adding into that problem as well. And one of the health system barriers that we need to consider is that if I look at one of the government like South Sudan, one of the barrier is that the allocation of the health budget to the Ministry of Health from the national budget has been quite low for very many years since the country gained independence. It has been 2%, but recently, I think last year, they opted to increase that to 10%. But that was a communication. But the actual release of these funds to the Ministry of Health to be able to provide these services through the government health structures has been, it has still delayed. And of course, that is not something that can be decided at our level or at our areas of operation. That's a government jurisdiction. I know in country, for example, in South Sudan, UNFPA has actually, through the partners that we have with them, they've supported the training in practice and also training for registered midwives. This kind of training that is done countrywide enables the midwives to come out, and at least right now, there are few developments that we have seen over the last 10 years. We can confidently say that every primary health care center has a qualified midwife. They may be few, but at least there is one or two, which is actually a great stride that we should work on. But then now, with another one of the health system barriers that the countries should focus on, or partners need to focus on, is how sustainable is this? And how can we make it run through? That it is not only funded by organizations, but it is also it is a part of the government. Young governments need to take this up and make sure that they are able to take this in. I have looked at the previous question that asked about good approaches that have outcomes for midwifery. I know, like in a context like South Sudan, which has access issues because of either the roads or because of the flooding, we've had mobile outreaches supported by most of the donors, UNFPA, we have OFDA, we have also other grants that support this. You'll find that these mobile outreaches deploy. It's a group of nurses, midwives, and clinical officers, including gender-based staff, WPE staff, who can actually provide services nearer the communities without communities having to travel. Now, this kind of approaches that we've put in place are short-term, but they are able to ensure that the deaths, the morbidities, and mortalities of women and children actually go down. And it doubles up also for the children because this increases.
Lillian, you're breaking up a little bit. Can you say?
Sorry. I hope you are able to hear my last session, and I'm saying that deploying these mobile outreaches with qualified staff improves the outcomes of women and children, not just for maternal health, but also for immunization. These countries, because of conflict, these areas, you'll find that immunization levels also are low. And of course, child morbidity and mortality also rates go higher. But with having these mobile outreaches, this has really improved. It's something that we can attest to. Back to you, Sarah.
Wonderful. Thank you so much. And I'm glad to end on that positive note. And we are at time now, so it is time to wrap up. So I just wanted to say a final thank you. Thank you, Lillian, Mushtaq, Angela, and Tamar for being here today and for sharing all of your expertise. We will be producing an event summary of today's discussion, and we'll be publishing it on our blog. This event has been recorded, so there will also be the recording either later today or first thing tomorrow that will be available. For everyone listening, we will share all of those resources with you after the event today. I'd also like to thank our partners at UNFPA for making this event possible, and also for all of our collaborators and speakers today coming from White Ribbon Alliance and the Interagency on Reproductive Health and Crises, and from IRC. Thank you so much for all your time and commitment to this event, but also to the work that you're each doing to help women and children in humanitarian crises. Please keep in touch with us. This has been really wonderful. And with that, I say good evening and enjoy the rest of your days. Thank you very much.
Thank you very much, Sarah.
Thanks, Sarah.
Thank you. Bye.